Hello everyone. So today our topic of discussion is genitourinary fistula. Okay, so let's start it. First of all, let's see what are the different questions which has come from in the last 5 year PYQ. So this is a question from FMG June 22. Here they was asked to identify the fistula. We all know that this is bladder and this structure is vagina. So fistula was somewhat here. They have shown us the details in the inset. Okay, so this bladder is also known as vesicle. So this fistula is vesico-vaginal fistula or VVF, what we see. The next question is from FMG December 2019. Let's see what this question is. That 32 years old lady with uterine fetal death during the labor pains. Now this lady fetus has died during the labor pains. So most common reason is fetal distress. After NVD, she continues passing of urine from the vagina. Now, what do you mean by continuous passing of the urine from the vagina? This complaint we will deal when we will study the genitourinary fistula in detail. So that time we will see the question. You were asked to prepare discharge card of a patient who had VVF repair. VVF is the fistula which we saw in this diagram, vesico-vaginal fistula. Now here this patient has got the repair of this vesico-vaginal fistula. For how long you will ask her to abstain from the sexual intercourse and delay conception. Sexual intercourse and conceptions are delayed, or you can say a patient is asked to have abstinence because during the intercourse and while conceiving the vagina and bladder they get pressurized. So they are asking what's the exact ideal time for the abstinence and the delay conception. So the answer to this question is 3 month abstinence and delay conception by 1 year. Okay, so let's study the genitourinary fistula now. Okay, out of all the different fistula, the VVF or the vesico-vaginal fistula are the most common. Okay, now what happened, how this fistulas, what is the etiology of this fistula? In India, the most common etiology of this fistula is obstructed labor. Okay, so let's see what happens in the obstructed labor. As you know that in the obstructed labor the head gets stuck. So can you see here, the head has got stuck here. Now due to the pressure of this head and due to the pressure of the uterine contractions, this due to the pressure of the head and due to the pressure of the uterine contraction on this whole area near this head, there is loss of the blood supply. So there is ischemia. Due to the increased pressure here, the blood flow gets stopped all to all the nearby areas. And if this ischemia is prolonged for a long time, as in the case of the obstructed labor, so then there is ischemia necrosis also. Then there is ischemia necrosis also. Due to this ischemia necrosis, the whole area where the pressure was there during the obstructed labor get sloughed or get necros. Okay, so you can see here then, and you can see here that this when this area will get necros, then what will happen, then these tissues will die and there will be a communication like this, and vesico-vaginal fistula will be formed. Now you all know that in the bladder there is urine, right? Now this urine, it goes into the vagina because now fistula has is there. Okay, so vesico-vaginal fistula is the reason of this which is formed due to obstructed labor, due to the ischemia necrosis. there the patient passed the urine from the vagina. So the answer to this question, continuous passing of the urine from vagina, is vesico-vaginal fistula. This is the answer. Now let's see the urge incontinence and stress incontinence. As you will see in our next video, that urge incontinence and in stress incontinence there is urine leakage, but that leakage is always from urethra, not from vagina. Okay, so this you should know that in fistulas only, in vaginal fistulas only, the urine will come from vagina, not from the urge incontinence or stress incontinence. In the case of the bladder rupture, the bladder will rupture and the whole of the urine will come in the peritoneal cavity, not in the vagina. So the answer to this question is vesico-vaginal fistula. I hope you are clear now. Okay, so now let's see what will happen and how we are going to diagnose. So the patient will come with the history that I am having the continuous dribbling of the urine from the vagina, and this dribbling will be 24 into 7, 24 hours, 7 days in the week, in the day, in the night, every time. So the word history given by the patient is continuous dribbling of the urine from the vagina. So when a patient will come with this complaint, of course now onwards we will have in the mind that this is the case of the vesico-vaginal fistula. Now after this complaint and having in the mind, we will perform the test, and that test is methylene blue 3 swab test. What is that test? In methylene blue 3 swab test, what we do is that we fill the bladder with methylene blue dye. Okay, and we in the see, I have filled this bladder with the methylene blue dye, and then in the bladder we put 3 swabs, as one by one, on 3 swabs. Okay, we put 3 swabs in the vagina, sorry, not in the bladder, in the vagina. In this way we will put 3 cotton swabs. I am making this swabs red here because my background is already white. Okay, so we have done two things. We have put the methylene blue dye in the bladder, and we have put 3 cotton swabs one by one in the vagina. Now if the fistula is between the ureter and the vagina, okay, so if the fistula is here, then of course the this swab will get blue. Okay, if the fistula is not, if the fistula is in the ureter, okay, if the fistula is in the ureter, I'm not talking about this fistula, I'm talking if the upper swab gets blue, then it means that the fistula is in the fistula, or the communication is between the ureter. As you all know, ureter is the uppermost. If this swab gets blue, it means that the communication is between the bladder and the vagina. Okay, and if this swab gets blue, lower swab gets blue, it means that the communication is between the urethra and the vagina. Okay, so in the case of the uretrovaginal, upper swab will get blue, and in the case of vesicovaginal, middle swab will get blue, and in the case of the uretrovaginal, as urethra is the lowermost, so lower swab will turn blue. So that was about the methylene blue 3 swab test. Okay, then you should also know, after these things, then you should also know that these are only this test is not the best test, and other than this test we have to do many more tests. Okay, so now let's see which more tests we have to do. Okay, so another test, as you know that now in the vesicovaginal fistula, the fistula is communicating with vagina, communicating with the bladder is communicating with the so bladder is communicating with the vagina, so infections will come here and high chances of UTI are there. So we have to take urine culture. A long back question has come in NEET PG that how we are going to take the urine culture. So as you know that midstream urine sample is usually taken, but here we will not take that because this midstream urine sample will have vaginal discharge also. So we will put the catheter here. So we will put the catheter here, mm, like this, and we will put the catheter, Foley's catheter here, and then we will take the sample because Foley's catheter is a device which can go up near the ureter and we can get a good sample of the urine. Okay, so the Foley's catheter is with via Foley's catheter or with the help of Foley's catheter, we take the urine sample of the patient with VVF. Okay, now next is that if this is not the if this is methylene blue 3 swab test is not the best test, then which is the best test? The best test is cystourethroskopy. Okay, the surgery which is performed for this VVF has got two names, and you have to learn these two names because this topic is getting importance day by day. Is Lexaco operation or Chaser-Moore operation. These two are different operations. You not need not to go into the deep of these operations. Just learn the name. Lexaco operation and Chaser-Moore operation, and out of these Chaser-Moore is best. As asked in NEET PG 2022, I have already told you after the repair of the VVF by Lexaco or Chaser-Moore operation, then the patient have to maintain 3 month abstinence and pregnancy has to conceive after 1 year. Now comes the question. Now, if the patient conceives after 1 year, then what is the mode of the delivery? As you know that most common reason of the vesicovaginal fistula is the obstructed labor. So, we will not prone this patient of VVF repair again to the obstructed labor. Okay, because again the fistula can be formed when the head will get impacted, and another fistula repair is very difficult. So we will always do a cesarean or abdominal delivery for this patient. Okay, now that was all about the VVF and all the expected questions we have covered. Now let's see about the another two vaginal fistula that we discussed in the methylene blue 3 swab test, uretrovaginal and urethrovaginal. Uretrovaginal, as you know, is upper at upper level than the VVF. So here soon you will see in our video that the sphincter control of the bladder is here at the bladder neck. External urethral sphincter is here at the bladder neck. Now in the case of the uretrovaginal, the patient complains that I am having dribbling of the urine in the vagina, but I have my voluntary control too, because voluntary control is at the lower at the lower end or at the neck of the bladder where urethra starts. So the history which is given by the patient of uretrovaginal fistula is that there is dribbling of the urine, and dribbling is very less. As you know, ureter has very less space, so dribbling is very less as compared to the vesicovaginal fistula, but the patient's voluntary control is excellent. Okay, now in the vesicovaginal fistula, the history of the patient was that I am having continuous dribbling of the urine from the vagina, or continuous passage of the urine from the vagina, and this urine is large in amount as compared to the uretrovaginal. Okay, and the uretrovaginal, as you all know, in the uretrovaginal fistula, as you all know, the urine comes in the urethra only during the micturition. So urine comes into the urethra only during the micturition. So if a patient has urethrovaginal fistula, then urine is going to come in the vagina only during the micturition. So patient will complain of dribbling of the urine into the vagina only during the micturition. Okay, that is all what you need to know about the uretrovaginal and the urethrovaginal fistula. That by the history you can come to know how we can differentiate uretrovaginal fistula, VVF, and the urethrovaginal fistula. Now let's see the another two fistula, which is at the number one, vesico-uterine fistula. What is vesico-uterine fistula? See here, this is vesicle and this is uterus. So there is the communication between the vesicle and the uterus. Now what will happen? Now why this communication is there? So for that you should know the anatomy, the organs which are lying here. Okay, now let's see. Here is the peritoneum. Now during every cesarean we reflect this peritoneum, and we incise the uterus and take out the baby. So with every cesarean this uterus wall gets thinned up, and this peritoneum also get lightens or get thin. So if the woman who is having more cesarean, then this will get thin with every cesarean, and as a result of this thinning, the give me just a minute. As a result of this thinning, there will be a vesico-uterine fistula. Now you all know that a lady menstruates in 4 days. Now due to the presence of this fistula, the menstrual blood will come into the bladder, and patient will suffer from hematuria, and that will be only during the menstrual cycle. So we can also say it cyclical hematuria or menorrhagia. So the a particular history given by the patient in vesico-uterine fistula is hematuria, which is cyclical or 4 days in a week, or menorrhagia. Now last but not the least fistula is the rectovaginal fistula. Here there is fistula between the rectum and the vagina. So as you all know, rectum contains flatus and feces. So the patient's complaints of passage of flatus and feces is from the vagina. So history given by patient is that my flatus and feces are coming from the vagina. And what is the reason of this is the improper repair of the complete perineal tear. What is incomplete, what is improper repair? You all know in the complete perineal tear, the rectum also get tears. So if any surgeon has not properly repaired that complete perineal tear, then there will be formation of rectovaginal fistula. And how we are going to treat this? First, for 3 months, we are not going to treat this patient, and we will make the colostomy. Then we will do, after 3 months, we are going to do the repair of this rectovaginal fistula. So first step in the rectovaginal fistula is colostomy. Okay, so that was all about the genitourinary fistula. Thank you.